We probably start with the definition of what success is. So from the Oxford English Dictionary, it's kind of defined as achievement of a desired result or outcome. So in the setting of periodontal treatment, and more specifically on non-surgical periodontal treatment, we often look at clinical parameters like the probing depth. We're trying to get it down to a certain measurement, and we're also looking at how inflamed the gingival tissues are. So ideally with like a bleeding score of less than 10%. That's all well and good in sort of clinical parameters, but for me success isn't just about achieving what we want as clinicians, but also whether the patient feels like the treatment is successful, what their expectations are, whether there's any complaints, and also I think successful treatment is avoidance of problems, whether you can identify them or you can't identify them. And sometimes if we're talking about problems that we can identify, we need to be educating the patient on why these happen and making sure that they understand why sometimes problems that we encounter during treatment is unavoidable. So I go through this with all of my patients. I think number one in trying to educate the patient is to make sure that they're on the same page. And I think in periodontics, it's really, really important because it's not just about what I do to get the result, but the patient also has to work with me to achieve the result. So I always start, this is your tooth, this is where the bone is, and this is where the gum is. So in healthy situations, I roughly explain the bone and the gum work together to provide structural support for the tooth. When there's gum disease or gum problems, what we're really worried about is whether there's been bone loss. And the bad thing about bone loss is that it doesn't grow back anymore. On top of where there's bone loss, the gums are generally inflamed. And that's why it's bleeding, that's why it's looking red, that's why it's swollen, and it might be painful. And so together, the inflamed gums and the bone loss, we call that periodontitis. And we work that out by taking measurements of your gums. And so when things are healthy, the measurement should be about 3 millimeters or less. And when there's problems, it's bigger than 3 millimeters. And the main reason why this happens is because of bacteria that grows around the teeth. So I break it down into two broad categories. It's basically soft bacteria that the patient can clean off. And then there's hard bacteria that we need to help you clean off. And the reason why it turns hard is because there's lots of minerals in the saliva and it can take in the minerals and calcify. So basically the bacteria grow on the teeth, it starts above the gum line, but it also grows underneath the gum line. And basically the inflammation of the gums is a reaction of the body towards the bacteria. It's basically it sensing that there's infection that's coming. So it's a defense mechanism. But if you don't clean off the bacteria, or if you can't clean off the bacteria, this inflammation continues to linger around, and it is actually what worsens and causes the bone loss to gum disease. And because of this, we often call gum disease a chronic inflammatory disease, which is a disease that's caused by long-term accumulation and persistence of inflammation. So once they understand this disease process, I go, right, so the treatment is, number one, oral hygiene. And that's making sure that they can continuously remove the bacteria adequately. Then I need to go around and help you do some cleaning of the stuff that you can't get rid of. And then we need to still continue this care ongoing, because when you slack off with the cleaning at home, that's when the gum disease can relapse again. So once I've got them on board, then I start to go over about possible problems that can happen. So this is just a very typical kind of consult that I would do with my patient, running all these things out. So when we talk about problems, it's something which is not, I guess, quite often reported in the literature. There's been a series of papers in Perio 2000, which is quite a good sort of summary kind of paper, and there's a whole issue in 2023 about errors. So I'm mainly focusing on periodontal treatment and non-surgical periodontal treatment. But if you're interested, they talk about surgical treatment and also implant treatment, so soft tissue grafting and things like that. So they broadly break down sort of problems into 4 different groups. So they talk about errors and harm, which they attribute more to sort of operator problems. Then they talk about complications and side effects, which is sort of like, may not be completely because of the operator. I think for me, I think it's quite academic to talk about, specifically what is an error, what is a harm. I think you kind of just break it down into I think of it as what is anticipated and what might not be anticipated. And sometimes for me, I don't think it's fair to only talk about the operator, because it can be many different things that can affect the outcome of treatment. So there are local and systemic factors that might relate to the patient, and specifically, I think a big one is poor oral hygiene, smoking, and also certain medical conditions as well. And they're the kind of things that we can probably anticipate. We might not be able to change significantly, but then we can educate the patient why we might run into certain problems, and why they might not be healing quite as well. And there are other technical factors, such as selection of tools and materials. I think in sort of standard conventional periodontal treatment, there's only a few tools that you can use, so it's not really a big significant factor in periodontal treatment. And then there's also the operator factors. I think a big part of it is experience. So you kind of learn from your previous mistakes or learn from sort of problems that have arisen. Now, before we, dive into more specific problems that might occur, I think a large part of it is sort of what happens on the day. You might be having a bad day, you might have a patient that's outside, that's been sitting in the waiting room for half an hour because you've had a slightly more complicated case, and they're yelling at the receptionist, and you're kind of like, I need to quickly finish this off. And I find in stressful situations, that's often when error can occur. It may not be intentional, but I guess identifying this, you can try and create an environment that you try and reduce the stress, such as rescheduling an appointment, or the receptionist having sort of the foresight to try and reschedule the books for you. Or maybe you just had a bad day coming into work and you're especially stressed that day. So I think a lot of problems that we encounter, especially operator related, is quite external to what may be happening in the clinic itself. Now, going more specifically into sort of problems that we might encounter in the treatment of periodontitis, number one is probably the soft tissue. So gingival tissues, I think when we're going subgingival, you definitely do cause some degree of trauma. Most commonly to the gingival tissues, but in my experience, you sometimes get trauma to tissues of other areas, such as the buccal mucosa and the tongue. And often it may not I don't feel like it's completely operator dependent. Maybe this particular patient just has a very active, robust fat tongue, and you're trying to clean distolingual margin, the calculus off that corner there, and they're just fighting you, and you're trying to get the tongue out of the way with the mirror, and you've got, because it's really, really hard calculus, you've got the ultrasonic on quite high, and then your mirror slips a little bit, and then you unintentionally cause some burn with the ultrasonic. So I find that's happened to me a few times, and so now I'm just very, very cautious of making sure that I get the assistant to help me. So in some ways, this is kind of things that I've learned over my practicing years as well. But it's not actually just the operator itself. I find sometimes I get trauma from my assistant as well when they're suctioning. They're trying to suction on the lingual aspect, and they often sometimes get the suction onto the floor of the mouth or onto the palate or things like that. And that generally causes a little bit of rash. Now, in general, these types of problems I'm not too concerned about. Probably the foresight that I would be having is to warn the patient that definitely after treatment, there's going to be some degree of pain. And usually I find it's very dependent on the patient. I would probably say things like patient factors like smoking. I find these patients generally heal a little bit worse as well. So these are sort of specific things that I look for in patients that might sort of make me warn them more of pain when I'm expecting that they might be in a little bit more pain. And I guess just the general severity of the periodontal disease is one of those factors too. The good news is that usually soft tissue damage, the mouth heals really well, and it generally heals quite quickly within 2 weeks. Now, on the topic of soft tissue, I think this is often what we see in periodontitis. Recession is a big thing, and it's probably an important thing that we need to talk about with patients, because this kind of appearance is exactly what I'm looking for successful outcomes. And it goes back to how I explain sort of the effects of treatment with the patient as well. So I go, look, we need to make these measurements, and in these areas there are problems because you've got a 7 millimeter and we're actually looking for it to be a 3 millimeter. And usually I'll go, okay, we're going to remeasure, and the goal is to get to 3 millimeters. Like, oh, okay, so the bone grows back. I'm like, no, the gum changes. So what happens is there's a reduction of inflammation, and that's what causes the reduction in the probing depth. So I would say in periodontal disease, treatment of it, you will inevitably cause gingival recession, and unfortunately when you have that happens quite severely, severe periodontal disease at the anterior teeth, at the front teeth, you tend to get quite significant recession. Now, there are a few things that we can try and do to address it later on, but I find a lot of patients who get very hung up about this, I'm sort of like, if we can't get the gum disease under control, you can't have anything else done. You can't go and see a dentist to see if they can do fillings there. That's a whole other set of problems. But I think at the root of it, we've got to make sure we get on top of the disease, and then we can see what can we do, what options are there. If we keep circling around it, you're sort of really stuck on this, oh my god, I'm going to get these black triangles, and it's going to look really ugly, then we may not ever even get to be able to find a solution for the patient. On the topic of soft tissue problems, I think bleeding can be sometimes a problem. Now, generally we, I guess, think of bleeding as medication related, which is, patients on blood thinners, whether warfarin, aspirin, and things like that. I think a lot of patients are on blood thinners. I don't, for sort of your stock standard periodontitis patient, I don't have much problem with post-op bleeding. Non-medication will be more sort of medical conditions, so things like hemophilia or Willebrand's disease. I generally, in private practice, don't see a lot of these patients, and I think if I do see one of these patients, I would be probably liaising with the medical colleagues and just seeing their medical risk. But I think a very easy way you can kind of scope and snoop out how big the bleeding risk in this patient is just asking them, do you bleed easily? Do you bruise easily? And they're like, oh yeah, I just accidentally knock myself and I get this massive bruise, or it takes ages for me to be able to stop bleeding. And I'm sort of like, oh, this seems a little bit scary. Or maybe it might change how I approach treatment. Instead of doing a half mouth, I might go, let's do just a quadrant and just see how you go, because inevitably you change and you reduce the surface area where it could be bleeding from. So you try and do it a little bit less, but just it'll take a little bit longer. But I find when I have had bleeding issues, it's probably in cases like this, when I'm anticipating that it's quite inflamed. So this can be one area. So with this, generally, we probably cut it out as well. But then when we cut it out, it can be quite difficult to stop the bleeding. And I find the cutting out and the cleaning doesn't take that long, but the stopping the hemorrhage control is probably the most difficult part of this. Or we have cases like this where I'm anticipating that I'm going to get lots of bleeding. So in these patients, I think patient education is extremely important, because when they're in the chair, that's something you can manage. But when you go home, sometimes they could bleed even after you've stopped the bleeding in the first place. And I think a lot of the times, the patient themselves are able to stop the bleeding if you just teach them what they should be looking for. So generally, I think number one, patients freak out when they see a lot of blood when they go home. So I always tell them, number one, stay calm, don't stress. If you see a lot of blood or like lots of blood clots, just get a clean piece of gauze and wipe all of the blood away, okay? Wipe it away and you have a look. Have a look at where, if there's any active sites of bleeding. So really look for, so example, if I'm on the left photo, obviously the most obvious area that could be bleeding is from that point. So you have a look at the gingival margin and see if there's actually seepage. If there is, then compression. And not just compression for 5 minutes, a good compression for like half an hour to 1 hour. So I often tell them, you gotta really pinch and make sure they pinch on the pink and not pinch on the white. So they often pinch on the teeth and think that that's enough, or maybe because they're pinching on the gum, they're like, oh, it's a little bit sore. So I might know, pinch on the gum, and I will show it to them on the side that's not numb. This is how hard you need to pinch, and your arm's going to get tired, so make sure you use your other hand to support the hand and just hold that there for a good half an hour. And generally, I don't have a lot of problems with patients calling me up with bleeding issues. And I think that is also, for me, a sign of success when you're not interrupted in your daily life with complications. Then we move on to hard tissue problems. So the main thing that we're concerned about from the literature is probably surface area roughness. And there's a lot of research looking into what's the effect of scaling on different restorative materials, on the tooth surface as well. I think for me, I'm not really that concerned about it. Well, and also, is there a difference between hand scaler or ultrasonics? Generally, on tooth surfaces, we kind of quote every stroke of the curette you could be removing between 7 microns to 20 microns of dentin. I think for me, I'm not really that hung up about how much tooth structure you remove, because I think if there's calculus there, that's a more rough surface than whatever I leave behind as well. So I'll do whatever I need to ensure that we remove the bacteria that's there. Now, so in the majority of cases is not a big issue, but could it cause damage as well? And yes, it totally can. And this is, I guess, one extreme case where scaling has caused significant tooth damage. And we'll come back to this a little bit later as well. So these are, I guess, a little bit more rare problems. So instrument breakage. So that doesn't look terribly difficult to fix up. That doesn't look terribly difficult to fix up either. Might need a little bit of open flap to access that. But I think this one takes the cake. This one looks quite significant in the sinus over there. So I wasn't aware that this was a thing or it could happen. But on the course of preparing for this talk, I was like, oh, these things could happen as well. So I guess just keeping in the back of the head and just being appropriate with the instrument usage, I think is quite important. Now, with hard tissue damage, this is also something that is quite relevant in periodontal treatment. So sensitivity after cleaning of teeth. So I find this is something that we can definitely preempt and warn the patient about. And usually they'll come back to me and go, oh yeah, my teeth are sensitive, but you told me about that. So they're not really that concerned about it. And so this happens because we've got to remove the calculus, the bacteria off, and we inevitably remove some tooth structure as well, and that ends up causing the dentinal tubules to be exposed. Now, I think most of the time, I would say oral hygiene is super important to maintaining or reducing the sensitivity, especially post-treatment. And earlier today, before lunch, we had a lot of information about toothpastes that can be used as well. And I guess in more difficult to control situations, there are certain resins and varnishes that you can use and also lasers. In general, I'm not a huge fan of putting restorations on those buccal cervical areas, because I just feel that in the majority of cases, you end up with some overhang that's there and you have persistent periodontal inflammation, and which can then relapse the periodontal disease as well. Now, I recently saw this patient, I was like, perfect. She came back and was like, my teeth are so sensitive, blah, blah, blah. I'm like, yes, we've got all this recession around, there's all this dentin that's exposed. I'm expecting things to be a little bit sensitive. But when I'm looking around, your cleaning is okay. It's not the best, because what's going on here? What's all that plaque there at the gingival margins? And then there's also calculus, which is very specific, really around the lower two front teeth there. And she's like, I just grow calculus there really, really easily. And I'm like, I don't know. Why is it only on those two teeth there? Why is it not on the other one? So to me, when it's very local like that, it's not really something that's systemic. Like, I wouldn't be like, this just happens to you because, you just build calculus really easily. So when you look at it from an occlusal view, it becomes a little bit more obvious what the patient is not doing. So I kind of look at it and go, okay, so I can see where you're cleaning to when you're cleaning the right-hand side. And then this is where you go to. So when you clean the right-hand side, you tend to hold the toothbrush like that. Then you get to a certain point and you switch to this way. And so there's an area where she doesn't overlap when she switches, which is exactly where there's a lot of calculus. It's just that I think that degree of calculus build-up is probably in my books unacceptable, and I think that's quite generous as well. So a lot of the times when we're looking at sensitivity, I think the first thing that I look for is how well is the patient cleaning. And a lot of the times they come back and like, my teeth are sensitive, my gums are sore, just like, I need to be really careful when cleaning. And I know you just have to get in there, you just follow my instructions and it'll feel better. And I think having that experience helps you stand your ground and go, you just need to follow what I asked you to do. And I would say, the majority of cases, it gets significantly better. Okay? Now, just on some other more sort of obscure and not really common things that I've encountered when I was preparing this talk. So fever is a possible side effect that could happen. So it generally happens when you go through a full mouth debridement protocol. And so the reason for this is historically we were concerned about cross-seeding of different pockets from one corner of the mouth, so we disinfect everything, you have a really strict chlorhexidine protocol. I generally tend not to approach things this way. Number one, because I'm lazy. I get really lazy I'm not lazy, I get very tired if I have to spend 2 hours cleaning the whole mouth of a patient. I'd rather break things up. And also, patients get tired too. They might open really wide in the beginning and they get tired and then they end up looking quite small towards the end. It just becomes, you're like fighting the patient and the patient's fighting you, and it's just not fun for everyone. So what happens with fever is when you have a lot of anaerobic gram-negative bacteria, there's a lot of endotoxins, RPS, and when you do cleaning, you do induce some bacteremia, which then can cause immune response. So generally the fever that's been reported from full mouth debridement protocols is from that. I'm not talking about sort of mild, moderate cases that you might clean the whole mouth for. I'm talking about full mouth of calculus and probably probing depth of like 7+. That's probably when I would be a little bit more cautious, going, maybe they might experience some fever, and just go, hey, you might experience this. It's all good. It's just something that will pass. Okay. Then you have issues with subcutaneous emphysema that has been reported in literature. I personally myself have not encountered this. From the literature, it tends to happen more with airflow devices, so air polishing devices, which is quite popular nowadays. We do have one in the practice, and my colleague does use it, and her hygienist uses it. We haven't encountered any problems, but just from the literature, they all seem to attribute it to air polishing devices. Herpes labialis, I think this is also quite rare as well. Enlarge, there's been one case report of osteonecrosis happening post-medication. So I think this particular patient from the case report was on denosumab, so Prolia. So that can happen, and I think in terms of enlarge, it's not that surprising considering trauma is something that could cause it, because you can see it from like denture, ill-fitting dentures as well. And then brain abscess, which I feel is just so uncommon that it's not something that I would be that concerned about. It's a little bit, from what I could see, the few papers that I come across, some were talking about really immunocompromised patients, and some were talking about young, fit, and healthy patients. And I think it's just so unusual and so rare that I wouldn't really, it's not something that's on my radar or in my head that I'm thinking about. So those are kind of common problem side effects that we might encounter in periodontal disease. Now, coming back to when things go really wrong in periodontal disease treatment. So this particular case, there's quite significant damage to the root of the tooth, and this is what the probing depths look like. So you can see that it's quite isolated around the mesiobuccal aspect of the tooth, and there was no mobility on the tooth. So I sent her off for a CBCT to just get a three-dimensional look on what it looked like, and that's sort of how it panned out. So you can see the bone loss is very isolated to just that mesiobuccal root. So I kind of was like, this may be something we could manage with root resection, since all the other roots seem to be quite healthy. The sinus looked like it could be difficult to manage as well. And the patient was a bit averse to having sort of extended treatment. So I guess looking at the indications for root resection is severe bone loss around one particular root. And I guess an important thing is just what's the supporting sort of structures of the remaining roots like? The crown root ratio, divergence, how are we going to maintain what's remaining there? So looking at the literature, the success of root resections is quite variable depending on who you quote. So it could be as high, the failure, it could be as low as 7% over 10 years to up to 38%. And I think it's very difficult to draw a sort of generalized response or generalized conclusion from the studies, because every study might have a different root that they're resecting. So generally, I think if you can have good health, the better condition the remaining roots are, the better the outcome. Now, generally, the failure of root resection is still due to root fracture, so that's probably from occlusal problems. Root caries is a problem, endodontic complications is also a problem, and also really relapse of periodontal disease of the remaining roots as well. So in this particular case, this is what it looked like. I'm very fortunate to be working with the endodontist as well, so I got the endodontist to, hey, can you do some endo on the tooth? And then with the MD root, he cleaned it out as well and put some sealing material in there. And so then I went in and did a root resection for the patient. It was done probably a month or two ago, so I don't have any more recent follow-up on the tooth. And I guess with these kinds of patients, you just have to take it one step at a time and just sort of see how things pan out. Okay? So I guess that's one of those cases that I'm sort of like, this is an unexpected, probably operator-related problem, and I think in these cases it's important to try and help the patient remedy the problem, whoever caused the problem. So I guess my take-home message is, problems happen with treatment. because that's just part of treatment. You encounter problems as part of treatment. So a lot of the times we can anticipate problems that are going to happen. So I think it's important to have this discussion with the patient so they understand and we set and manage their expectations. Mistakes can happen. It's not great. And I think the important thing is, we're all human, but we should learn from our mistakes and make sure that we can help the patient remedy the mistakes and also to rectify and not commit the mistake again. So I think the important thing in terms of problems and mistakes and errors is, can they be anticipated or are they unexpected? I think it's important to sort of understand all these possible scenarios that could happen to help you achieve a successful outcome. Thank you, Miriam, for listening to me.
Yes, thank you, Dr. David Chen, for your wonderful lecture this afternoon. So, on behalf of the lecture committee, I would like to invite Dr. Tim to present the flowers and the certificate of appreciation to Dr. David Chen. Dr. Tim, please. Dạ, một lần nữa xin hội trường chúng ta một tràng vỗ tay cảm ơn thầy David Chen. Yes, thank you, Dr. David Chen again, and thank you, Dr. Tin. Yeah. So next speaker, I would like to introduce Professor Sonny Stephen. Professor Sonny Stephen is now head of pediatric dentistry at Sydney Dental Hospital. He also the examiner of Australian College of Dental Surgery and immediate past president Australian and New Zealand Society of Pediatric Dentistry. Dạ, một lần nữa cái báo cáo viên tiếp theo thì xin trân trọng giới thiệu đến quý thầy cô, quý đồng nghiệp cùng tất cả các bạn. Thầy Sonny Stephen. Thì thầy Sonny Stephen là hiện nay là trưởng bộ môn nha khoa trẻ em của bệnh viện, trưởng khoa nha khoa trẻ em của cái bệnh viện nha khoa Sydney, và thầy cũng là một trong những cái đánh giá viên trong cái hội đồng của giáo dục nha khoa của Úc, và hiện thầy là cái cựu chủ tịch của cái hiệp hội nha khoa nha trẻ em của New Zealand và của Úc. Ladies and gentlemen, yeah. Yeah. Xin lỗi thầy cô. Yeah. Thầy hiện nay là chủ tịch của hiệp hội cái nha khoa trẻ em quốc tế, và thầy đang là giám đốc của cái nha khoa trẻ em ở khu vực của Southside của Úc. Ladies and gentlemen, please welcome Professor Sonny Stephen.
Thank you. Thank you very much for a kind invitation to speak today, and also for the kind introduction. I've been here many times, and it's always a pleasure to come, and it's absolute honor and pleasure to talk to all of you. Just a quick question. How many of you are dental students here? Raise your hands. Lots of dental students. Excellent. Very good. Okay. Move. Moving. Okay. The reason why I'm here today is to provide you as an audience an evidence-based update on contemporary contemporary pulp therapy in primary and mixed dentition. The topics we're going to cover today is contemporary research and findings in the field of pulp biology, diagnosis of pulpal conditions in primary and permanent dentition, case selection, pulp therapy options for primary and young permanent dentition with an emphasis on vital pulp therapy, VPT, which is what's commonly mentioned in literature, the role of bioactive calcium silicate cements in vital pulp therapy, management of young permanent teeth with trauma resulting pulpal exposures. And I've got two of my colleagues sitting in the back translating for me, T and her friends. Good? Am I going slow enough, guys? Because they actually requested me to go really slow. Okay, that's my second family outside Sydney, the Pediatric Dentistry Department at National Hospital of Odontostomatology in Ho Chi Minh City. I've known these guys for over 25 years, and they're all still there. So great, including the current head of department, Dr. Chan, who was one of the students when I first came there. So it's always a pleasure to come back. I also wear another hat, which I'm unashamedly going to say. I'm the president of the International Association of Pediatric Dentistry, and it gives me immense pleasure to say, as the global voice of children's health, oral health, we are a group with 87 national member societies. But the most exciting bit is our newest member is who? Vietnam. It took a while, but we did it. So, we welcome Vietnam to the global IAPD family. Vietnam was represented very well in our recently concluded IAPD meeting in South Africa, and we really look forward to Vietnam being closely associated with IAPD. Currently in our committee, we have Professor Nook and Professor Ha Tu from Hanoi, and this is the current board of directors, and I'm really hoping in the coming years we will have few members from Vietnam. So Vietnam is really doing well in pediatric dentistry, and the reason why I asked how many students are here, let me tell you guys, the best specialty in dentistry is what? Pediatric dentistry. If we pediatric dentists don't treat those children well, all that you heard today is useless, because we have to do the groundwork. We teach the kids how to brush. We teach the kids what to do. We tell the parents how to do it.